Sí.
Hola. Hola, vamos a empezar en tiempo. Buenos días a todos y bienvenidos a al último día de este excelente congreso de GeSIDA. Gracias por estar aquí. Seguro que algunos habéis tenido una noche un poco tormentosa y por eso la gente irá entrando un poquito con retraso. La mesa que tenemos hoy aquí, bueno, mi nombre es Nacho Bernardino. Yo trabajo en el Hospital de la Paz de Madrid. Y mi comoderador, que se tendrá que presentar porque nadie le conoce seguramente.
Bueno, pues ya me conocéis, soy Pepe Alcamí, que actualmente trabajo en el Hospital Clínic de Barcelona.
Bueno, es un nuevo junior aquí en la mesa con nosotros. Y bueno, la mesa de hoy es la sesión plenaria de EACS GeSIDA, la sesión conjunta, y tiene el título de la PrEP en Europa y en España, Compartiendo experiencias. Os aviso que vamos a hacer preguntas después de la primera ponente porque se tiene que ir y tiene el transfer muy justito. Y entonces yo quería deciros que tenemos el gusto, I will switch into English. We have the privilege to have here with us to Professor Deniz Gökengin. Professor Deniz Gökengin is working at the Department of Infectious Diseases and Clinical Microbiology, Faculty of Medicine at H University in Turkey. She also has been acting as a director at the H University HIV/AIDS Research and Practice Centers since 2009. She is a governing board of EACS and a European board member of International Union of STI Europe. She is an excellent speaker, and I would like to thank you for accepting our invitation. And please, the floor is yours, Deniz.
Gracias, estimados moderadores. Buenos días, estimadas colegas. Es un verdadero honor y una gran alegría poder dirigirme a ustedes hoy. Quiero expresar mi más sincero agradecimiento a Esteban Martínez y a todo el comité organizador por su generosa invitación. Si me lo permiten, continuaré en inglés. Estudio español, pero aún lo hablo solo un poco. These are my disclosures. So it's been more than a decade since the IPREX study showed high efficacy of TDF-FTC to prevent new HIV infections. And many other randomized controlled trials followed, confirming these results in various communities and populations. And also, data from real-world settings had great results. These are 3 examples from 3 different countries showing significant reductions in new HIV infections after PrEP implementation started. A few years later, TAF-FTC was shown to be non-inferior compared to TDF-FTC, and it received EMA approval in 2019, but Gilead decided that they would not apply for it received FDA approval, but Gilead decided not to apply for EMA approval. So all of these studies showed that when used with high adherence, daily oral PrEP was very good in achieving a decrease in HIV infections, especially when used with in combination with other preventive methods. However, while all these good things were happening, we were also starting to have concerns about the availability, accessibility, acceptability of PrEP, and we also had serious concerns about people using PrEP would have risk compensation and the prevalence of STIs would increase. Now let's take a look at PrEP uptake in France after 2 years of its approval. France was the first country to start implementing PrEP as a national strategy in Europe, and it was fully reimbursed. This study includes people who are non-PrEP users. So there are three groups, as you can see in this purple group. These are the people who are eligible to PrEP. The large one are people who are aware of PrEP, and this group is the people who have intention to take PrEP. And the combination of these three is only 15%. And if we look at those who are eligible to PrEP, only 50% are eligible and aware and have the intention to take PrEP. So even if it's a national strategy, even if it's totally reimbursed, people sometimes may choose not to use PrEP. And younger age, student status, and living in a small city were significantly associated with PrEP non-use. In terms of risk compensation, there are conflicting results. This study is from US, including MSM, using PrEP, and showed that there was no change in the number of male partners, partner HIV status, sexual positions used after PrEP started to be used. However, the diagnosis of any STI was much higher during PrEP use compared to the prior PrEP use. However, the authors were not sure whether this was a real, actual increase in STIs, or was it due to increased STI screening, because, you know, we have to screen people who are using PrEP frequently. Another study from Spain, including MSM on PrEP, followed them for 2 years and showed a 78% reduction in condom use for anal intercourse, and this was a significant change. But there was no change in the number of sexual partners, no increased consumption of recreational drugs, and no significant change in the incidence of STIs over time. So we should always remember that these populations have already high STI rates even before using PrEP. And now we have new PrEP options, which will be probably more easier to use. And this study looks at the interest and the intention to use long-acting PrEP among MSM in several countries in Europe. And you can see that both overall and for those who are currently using PrEP, the interest and the intention to use is quite high. So people are looking forward to using long-acting PrEP. The first long-acting formulation that received EMA approval was cabotegravir in 2023. And you can see there are many countries and regions with cabotegravir approval. And we all know the excellent results of lenacapavir in preventing HIV infections, both in MSM and women. And now lenacapavir started to receive regulatory approval, and EMA approval was given in August 2025. And this is the first European real-world implementation results of the long-acting cabotegravir from Italy, including 265 participants, majority cisgender, gay, bisexual, MSM, and almost 90% had previous oral PrEP experience, and almost half had suboptimal use. And the adherence to injections was almost perfect, over 95%, had a favorable tolerability, and there was no breakthrough infection. And as you can see here, many people, the majority of the people, stayed on the injections until the end of the study. So since its approval, PrEP has become available on a global scale, either as a national strategy or demonstration projects or clinical studies, with a slow and steady increase, reaching more than 8 million initiations in the last quarter of 2024. However, in 2020, UNAIDS announced that despite all this progress, the PrEP target of 3 million people on PrEP by 2020 was unmet. So now let's look at what gaps and barriers we have. This study shows the PrEP gap in Europe. The PrEP gap is defined as people who are very likely to use PrEP if it's available and accessible, compared to those who are already on PrEP. And the PrEP gap for the European region is around 17%, ranging from 4% to almost 45%. And let's look at the left side of this figure. You will see mostly Central and Eastern European countries, and several of them are non-EU countries, and they have a larger gap than the countries on the western part of Europe. And you can see here my country having the second largest gap right after Russia. This is the status of formal PrEP implementation in Europe for 2023. In these dark greens, guidelines are implemented and PrEP is nationally funded. Light greens, guidelines are implemented, but PrEP not nationally funded. The yellow ones, guidelines are developed but not implemented. Blue ones, no guidelines developed. In fact, we did develop our guidelines. And in several countries of Central and Eastern Europe, no data is available. And ECDC results data for 2023 showing the number of people receiving PrEP at least once in the last 12 months. Only 34 countries could provide this data across Europe, and you can see there is significant variations between the numbers between countries. And again, on the right side, where the numbers are lower, you will see Central and Eastern European and Central Asian countries. In the Euro guidelines in Central and Eastern European Network Group, which includes around 27 countries as members, we asked several questions on PrEP systems in the countries at 3 different time points. So compared to 2018, in 2025, there was a significant progress in PrEP licensing and PrEP recommendation included in the national guidelines, but there are still gaps here. PrEP prescription free of charge within the public health system is only available in 1/3 of the countries. For the others, people have to pay for the drugs or for the drugs and tests together, or they have to go to private practice, and in 11% of the countries, PrEP is still not prescribed. PrEP is available either in the generic form or both generic and original forms, but in 22%, it is not available in pharmacies. The number of PrEP offering centers and the estimated number of people on PrEP has increased significantly within these years, but you can see that there's a high rate of informal PrEP use still. And this is the results of only the 2025 survey. You can see 4 countries here where PrEP is still not available. So there are several studies showing that some key populations have lower access to PrEP, and there are severe inequalities between populations. Black MSM and women, ethnic minorities, migrants, young people, and people who inject drugs, who are in greater need of PrEP, have lower access to PrEP. This is a recent report again from ECDC showing the populations eligible for PrEP in the national guidelines. And as you can see, gay men and other men who have sex with men, transgender people, and sex workers were the most frequently mentioned populations in guidelines for PrEP eligibility, both in EU and non-EU countries. But other populations, such as people who inject drugs, prisoners, others probably including migrants, are not as frequently mentioned. And again, ECDC data shows the number of MSM who received PrEP at least once during 2023, and percent of MSM on PrEP. And only 19 countries could provide data for this, and you can see significant variations between countries in numbers. Again, Central and Eastern European and Central Asian countries have lower numbers. For the percentages, they are acceptable. The MSM have greater access to PrEP, we all know that. But I cannot say the same for women. This is the women graph. Again, significant variations on the numbers between countries and much lower rates of women who are on PrEP compared to MSM. And it is even worse for migrants. Only 7 countries could provide data for migrants. And some countries, such as Malta, United Kingdom, and Cyprus, which have high number of migrants, have much lower rates. And this is the availability of PrEP for undocumented migrants. You can see in the greens, very few countries can provide PrEP for migrants if they meet the eligibility criteria. 6 years ago, ECDC sent a survey to its focal points asking them to list the barriers to implementing PrEP. And the major barriers were the cost of the drug, the technical capacity being limited, cost of service delivery, feasibility, and concerns about increased transmission of other STIs. 6 years later, the same survey was given one more time, and now we see a shift of answers to PrEP not being available in all parts of the country, difficulty reaching certain key populations, and having long waiting lists. But I should remind you that these were focal points, not healthcare providers who are in direct contact with people who are in need of PrEP. And we asked similar questions to our country members in the Euro Guidelines in Central and Eastern European Network Group at 2 different time points. And you can see that the barriers listed here are quite different from the barriers listed by the focal points, and there has been almost no change within time. Lack of knowledge of people in need and not being reimbursed being the most common barriers. And here you see the cost of the drug. It is still a major problem for initiating PrEP. There are also individual barriers to PrEP access, people with lower education, who are unemployed, who have no money to spend for basic needs, who are less engaged with their communities, who live in smaller cities, and who have less knowledge on PrEP, have lower access to PrEP. And another important issue is the US exit from the WHO and the recent freezing of UNAIDS PEPFAR funds. EACS sent a survey to its members questioning these, and 12 members from these countries responded that they were beneficiary of these funds and they were impacted by the restrictions. 3 reported that there was uncertainty about the provision of ART, PrEP, and PEP, and 1 reported that prevention programs have become much more difficult. And prevention programs were listed among the most affected areas. In 2023, EACS, ECDC, and CHIP started a new project, European Standards of HIV Care, to define the standards of high-quality HIV prevention and care across the care continuum in Europe, and to develop a tool to audit performance against the standards at the national, clinical service, and community level. The steering committee defined 12 modules, and 2 modules, PrEP and testing, were prioritized. And the working groups worked on these modules, defined quality statements, and for each quality statement, indicators were also defined, and a target was determined for each indicator. And these 2 modules are now finalized, and they have been audited. Here's an example of the audit for one of the indicators in the PrEP module. And this was the target defined for this module. And you can see there is significant variations between countries, and several countries are below the target. In conclusion, there has been great progress in PrEP availability in Europe. However, PrEP uptake is still not adequate to make a significant impact to end the epidemic. We still have much more to accomplish in terms of access and free access to PrEP. We need to consider socioeconomic, political, and cultural variations between countries because they have a significant impact on policies to be developed. We also need to consider major social, individual, and structural barriers. And developing the standards of care was a good starting point because this may encourage countries to see what their gaps are and to take action to overcome their barriers. If we are to have a realistic chance of reaching the UNA's goals, we need to give a high priority to PrEP targets. So I would like to thank all my colleagues who are in the ECEE network group and to Taimur Nouri for allowing me to use several of his slides. Muchas gracias.
Muchas gracias, Deniz. Tenemos tiempo ahora, vamos a hacer las preguntas ahora. Si queréis, por favor, ir yendo a los micrófonos. In the meantime, I would like to make a comment and a question for you. A discussion, at least here in Spain, is one of the discussions is trying to incorporate the new forms of PrEP, the A-like PrEP, because it's an opportunity to reach, let's say, people that they are not reaching oral PrEP or vulnerable populations. But with your data, it's amazing that apart from the huge efforts that have been done in the recent years, becoming the PrEP more available, there is a lot of work to do with the oral PrEP. So what do you think, if we have the new formulations, we are going to have better data than we currently have, or we're going to stay the same?
Well, of course, we all want to use the easier to use PrEP formulations, and our people who are in need of PrEP are looking forward to it. But there are, first of all, regulatory processes. They take too long time to have it accepted in several countries. My country, for example, it takes 2 or 3 years to have a new formulation to get regulatory approval. And it's similar in many Central and Eastern European countries, especially non-EU countries. There are also, how can I put it in words, political and religious concerns about allowing people to use PrEP, any kind of PrEP. We had to fight a lot in our country to get TDF-FTC registered for PrEP, but I don't think it will ever be fully reimbursed, because probably you hear the news about our country. We have a very rightist government. I don't think it will be allowed. And many countries in Central Eastern Europe have similar problems. And there are also economic problems because these formulations are quite expensive. I'm sure you all have heard the price of lenacapavir, and there will be negotiations for South African or African countries probably with the reduction in price, but I don't think the European countries will get any reduction for lenacapavir. So I don't see much future in the short term, probably maybe in the long term, but in the short term I don't see much future for the long-acting injectables used as PrEP in my region, Central and Eastern Europe. Western Europe is a different story.
Mm-hmm. Any question? One quick question for you. What do you think we should do to reach these vulnerable populations regarding PrEP?
Well, that's another major obstacle, again, in many countries. First of all, we need to know who our key populations are. I shall give an example from my country. We have thoughts about who our populations may be, but we don't have any study confirming those populations, because we haven't done any integrated biobehavioral surveys up to date. There's only one behavioral survey, which was run by our AIDS Society, not by the government, and that was only done in Istanbul, because on a country-wise basis, it's not possible for a society to run that study. It should be done by the governments. However, our government has no intention to run a survey. So if you do not know who your populations are, how they operate, what their behaviors are, and what their needs are, it's not possible to access those populations. You have to sit face to face with them and to learn what their needs are. And then you can negotiate what you can do for them. But if the health authority does not do that, then there's no chance of reaching the populations.
Hay una pregunta ahí, Oscar.
Thank you so much for your presentation. And we work a lot on talking about how important it is doing STI testing in PrEP programs. However, in some European countries, this has been changed in the last months. What do you think about this idea of simplify the PrEP program and not testing STIs? Thank you so much.
Thank you very much for this question. Yes, I am aware. In fact, it was discussed various times in International Union for STI conferences. And there's a study by Chris Kenyon from Belgium, maybe you have seen it, screening asymptomatic people, especially for chlamydia, was shown to be useless. So we are spending probably too much time and too much money and too much effort to screen people, and I think we should give more time and effort and money on other things. That's my thought. And there are people who are using informal PrEP and they are not screened for anything. And as I have shown you, there is still conflicting reports about whether the STI incidence has really increased in PrEP users or not, because they already have a high STI incidence and most of them are asymptomatic and do not require treatment. So probably in the following years, we are going to stop screening so frequently, at least not every 3 months. Thank you.
Thank you very much, Deniz. We're going to move to the next speaker. Thanks very much.
Thank you.
Thank you.